Welcome to this video entitled Asthma. Asthma is a chronic inflammatory disease of the airways that affects approximately 8% to 10% of the U.S. population. Approximately 7 million of these people are children. It is one of the leading causes for both outpatient and hospital care, with approximately 500,000 hospitalizations and approximately 1.2 deaths per 100,000 annually, according to http://www.cdc.gov/nchs/fastats/asthma.htm, accessed May 30, 2010. At greatest risk for hospitalization with asthma are African Americans and children. African Americans are 2.5 times more likely to have emergency room visits and be hospitalized for asthma and are 5 times more likely to die from asthma and asthma-related symptoms, according to Bryant Stephens in 2009. The cost for asthma-related treatment in 2007 was estimated to be $37.2 billion, according to Campbell and Balmer in 2009. Approximately half of all cases of asthma develop during childhood and another third before age 40. However, asthma can begin at any age, and it can affect both sexes and all cultures. An expert panel was commissioned by the National Asthma Education and Prevention Program, abbreviated as NAEPP, Coordinating Committee, coordinated by the National Heart, Lung, and Blood Institute, abbreviated as NHLBI, of the National Institutes of Health. They developed 2007 guidelines for the diagnosis and management of asthma. These guidelines were modified from the 1997 and 2002 guidelines. Let's now look at the causes of asthma. Childhood onset asthma is strongly related to atopy. Approximately 80% of all people with asthma have allergies. Adult onset asthma can be caused by factors such as coexisting sinusitis, nasal polyps, sensitivity to aspirin or non-steroidal anti-inflammatory drugs abbreviated as NSAIDs, and occupational exposure to workplace materials. Those with the greatest risk for development of asthma are children with atopy and a family history of asthma. Several factors increase the severity of asthma. These include untreated rhinitis or sinusitis, gastroesophageal reflux disorder, abbreviated as GERD, aspirin sensitivity, sleep apnea, stress, depression, exposure to sulfites or beta blockers, and influenza. Next we will discuss the pathophysiology of asthma. Asthma is a chronic inflammatory disorder of the airways characterized by airway obstruction, inflammation, and hyperresponsiveness. There is increased resistance to airflow and a decreased flow rate from airway obstruction. Hyperinflation distal to the obstruction, altered pulmonary mechanics, and increased difficulty breathing are a result of the airway obstruction. In the healthy human airway, there is normally a fine balance among immune cells, the epithelium, and the host immune response. Airway inflammation in asthma reflects a distortion of this balance and is orchestrated through complex interplay between multiple effector and target components. There are complex interactions among inflammatory cells, mediators, and the cells and tissues in the airways. Atopic asthma causes bronchospasm, resulting from increased responsiveness of the smooth muscle in the bronchioles to external stimuli. This, in turn, promotes a release of endogenous allergic mediators from the mast cells. These mediators include histamine, leukotrienes, and eosinophil chemotactic factor. There are 2 phases of symptoms, the acute phase response and the late phase response. The acute phase occurs within a few minutes and lasts for several hours, during which there is an interaction of allergens and macrophages. Upregulation of T cells causes the production of interleukins. The response in this phase is bronchospasm. The late phase response occurs in 2 to 6 hours, and lasts approximately 12 to 24 hours. T helper, abbreviated as TH, lymphocytes are recognized as having a central role in asthma. It is thought that individuals predisposed to allergic asthma have an imbalance favoring Th2 cells, which produce a family of cytokines that mediate allergic inflammation rather than favoring Th1 cells, which normally produce cytokines to fight infection. The hygiene hypothesis suggests that reduced exposure to other children, frequent antibiotic use, and reduced exposure to certain infections, e.g., tuberculosis, measles, and hepatitis A, promote the development of a Th2 phenotype more prone to respond to environmental allergens. This gene-by-environment interaction is offered as a plausible explanation for the observed higher prevalence of asthma in westernized countries. Mast cells are critical in mediating the acute response in asthma. While classically, mast cell activation occurs following the binding of antigens to Fc-epsilon-R1 bound, antigen-specific immunoglobulin, IgE. They may also be activated through other mechanisms, including stimulation of complement receptors and Fc-epsilon-R1 and via toll-like receptors, abbreviated as TLRs. Basophils have a crucial role in initiating allergic inflammation through the binding of antigen-specific IgE antibodies at the Fc-epsilon-R1. Basophils also drive Th2 cell differentiation of activated naive CD4+ T cells via the production of interleukin IL-4 and direct cell-cell contact. Murine studies show that following activation, basophils migrate in small numbers to adjacent lymph nodes. Using a basophil Fc-epsilon-R1 specific monoclonal antibody, it has been demonstrated that the presence of basophils but not mast cells is an absolute requirement for Th2 cell differentiation. Basophils also increase humoral immune responses on repeat antigenic exposure in the presence of activated CD4+ cells through the release of IL-4 and IL-6, which provide support for B-cell proliferation and antibody generation. Pulmonary dendritic cells are potent antigen-presenting cells with the capability to rapidly migrate to draining lymph nodes, suggesting an innate role in initiating immune response against airborne antigens. Hence, dendritic cells may dictate the subsequent T-cell response. Long-lived cytokines, such as ILS, activate eosinophils and T lymphocytes in the airways and release mediators that reproduce the acute asthma attack. Non-atopic asthma does not have an allergic cause, but can be a result of exposure to drugs, such as aspirin, non-steroidal anti-inflammatory drugs, or beta-adrenergic antagonists, chemical irritants, chronic obstructive pulmonary disease, dry air, excessive stress, and exercise. These cause stimulation of the parasympathetic reflex pathway with release of acetylcholine, which constricts bronchial smooth muscle. In acute, severe exacerbations of asthma, there are increased eosinophils and neutrophils within the airway, with the increase in neutrophils proportionately higher than that of eosinophils. Inhaled corticosteroids reduce airway eosinophils, but increase airway neutrophils and increase the expression of the neutrophil chemoattractant IL-8, which is associated with loss of asthma control. Increased permeability and sensitivity to inhaled allergens, irritants, and inflammatory mediators is a consequence of epithelial injury. The chronic inflammation of the airways that is characteristic of asthma can cause thickening of the basement membrane and the deposition of collagen in the bronchial wall. These changes cause the chronic small airway obstruction seen in asthma. The release of inflammatory mediators causes bronchospasm, vascular congestion, vascular permeability, edema, production of thick mucus, and impaired mucociliary function. Next we will discuss the pharmacogenomics of asthma. Inhaled beta-2 agonists, such as albuterol, marketed as Preventol, are used to control acute attacks of asthma and are prescribed to be used, as needed. Several studies have shown that some patients benefit from the use of short-acting beta-2 adrenergic agonists, abbreviated as SIR-Bars, whereas others do not. This variation in response is partly explained by the alteration in the amino acid sequence of the protein or altered transcription of the beta-2 receptors. Patients with the beta-2 receptor arginine genotype experience poor asthma control with frequent symptoms and a decrease in scores on forced expiratory volume in 1 second, abbreviated as FEV1, compared with patients who have the glycine genotype. Studies show that 17% of whites and 20% of African Americans carry the arginine genotype. Leukotriene modifiers block the 5-lipoxygenase, abbreviated as 5L, and LTC4 synthase pathways, preventing leukotriene-mediated bronchoconstriction. Only a minority of patients benefit from treatment with leukotriene receptor agonists. Polymorphism in 5-lipoxygenase and LTC4 synthase pathways has been identified. Approximately 5% of patients with asthma have the 5-lipoxygenase polymorphism. Patients who have the 5-lipoxygenase polymorphism show a greater improvement in their lung function with zafirlukast therapy compared with patients who have the normal 5-lipoxygenase genotype. Similarly, polymorphisms in the LTC4 synthase gene may predispose a person to asthma. Patients with the variant LTC4 synthase genotype have higher levels of cysteanyl leukotrienes, which have been linked with severe asthma. The use of leukotriene modifiers in this population may be beneficial. Variation in the genes involved in the biologic action of inhaled corticosteroids may explain the variability in response and adverse effects to inhaled corticosteroids. Polymorphisms in corticotropin-releasing hormone receptor 1 and T-box expressed in T cells have been associated with improved response in patients with asthma. Although these findings are promising in predicting therapeutic response to asthma medication, the usefulness in clinical practice is still under investigation. Prospective genetic testing could be beneficial for drugs in which a clear genotype-response relationship has been demonstrated. Let's now look at the diagnostic criteria of asthma. Key indicators for diagnosing asthma include the following. 1. Wheezing on exhalation. 2. History of cough that is worse at night, recurrent chest tightness, and recurrent shortness of breath. 3. Reversible airflow restriction with variability during the day. 4. Increased symptoms with exercise, viral infections, exposure to allergens, change in weather, exposure to irritants, stress, and in women during their menstrual cycle. And 5. Awakening at night with symptoms. When the practitioner suspects asthma, further evaluation is called for by measuring pulmonary function. Obstruction of small airways is indicated if there is a reduction in forced expiratory volume in 1 second, abbreviated as FEV1, in peak expiratory flow, abbreviated as PEF, in the ratio of forced expiratory volume in 1 second to fluid volume capacity, abbreviated as FEV1 to FVC, or in the mid-expiratory flow rate. If asthma is suspected, a beta-adrenergic agonist is administered and pulmonary function tests are repeated in 15 to 30 minutes to see if there is an improvement in test values. An increase of peak expiratory flow or forced expiratory volume in 1 second exceeding 12% from baseline values strongly supports the diagnosis of asthma. Normal forced expiratory volume in 1 second to FVC is 85% for 8 to 19-year-olds, 80% for 20 to 39-year-olds, 75% for 40 to 59-year-olds, and 70% for 60 to 80-year-olds. Asthma is classified according to 4 steps, which are based on the frequency and intensity of presenting symptoms: intermittent, mild persistent, moderate persistent, and severe persistent, as shown in Table 25.1. There can be movement up and down the steps, depending on symptoms. Pause the video and carefully scrutinize Table 25.1 summarizing the classification of asthma before proceeding to the next slide. Let's now discuss initiating drug therapy. Because asthma is a chronic disease, medication is needed for treatment. However, non-pharmacologic management of asthma also is an essential part of therapy. Patients must be aware of what triggers their asthma symptoms and should remove or avoid all precipitating factors. Smoke, seasonal allergies, animal dander, and cockroach droppings are strong triggers for asthma exacerbations. Stress and depression can also cause an exacerbation of asthma. Outdoor exercise and exertion also should be avoided when pollution levels are high or temperatures are extreme. Because GERD plays a role in asthma symptoms, the clinician should evaluate the patient for GERD and treat for the problem. See Chapter 30 for a discussion of GERD. Tight medication control of asthma is desired. 2 categories of drugs are used in asthma: long-term medications to control symptoms and quick relief medications, or rescue medications, to treat acute exacerbations. Long-term control medications include inhaled steroids, cromolyn sodium, marketed as Intal, others, and nedocromil, marketed as Tiled, leukotriene modifiers, and methylxanthines. Quick relief medications are bronchodilators, beta-2 adrenergic agonists, and systemic, that is oral, corticosteroids. Medications are available in oral forms, nebulizer solutions, and metered-dose inhalers, abbreviated as MDIs, which deliver a predetermined amount of medication with each inhalation. Recommendations for the initiation of therapy in neonates to children age 4 include 4 or more episodes of wheezing in the past year that lasted more than 1 day and that affected sleep, and those who have risk factors for developing persistent asthma. 1. Either one of the following: parental history of asthma, a physician diagnosis of atopic dermatitis, or evidence of sensitization to aeroallergens. 2. Or 2 of the following: evidence of sensitization to foods, 4% or more peripheral blood eosinophilia, or wheezing apart from colds. We will now discuss the goals of asthma therapy. The goals of asthma therapy, as determined by the National Asthma Education and Prevention Program abbreviated as NAEPP in 2002, include the following. 1. Minimal or no symptoms. 2. Normal peak expiratory flow rate with variations of less than 20%. 3. Minimal episodes of exacerbation. 4. No emergency visits. 5. Minimal need for, as needed, beta-2 adrenergic agonist. 6. No limitation of activities. 7. Minimal adverse effects from medications. 8. Decrease in or amelioration of the long-term airway remodeling, leading to irreversible lung changes. And 9. reduced morbidity and mortality. Let's take a closer look at inhaled steroids. Inhaled steroids are the most effective therapy in the treatment of asthma and are indicated for long-term prevention of symptoms and the suppression, control, and reversal of inflammation, as shown in Table 25.2. And now we will consider the mechanism of action of inhaled steroids. Inhaled steroids are very lipophilic and quickly enter target cells of the airway and bind to cytosolic glucocorticoid receptors. Glucocorticoid receptors may directly bind certain transcription factors that are activated by cytokines. Inhaled steroids reduce the number of circulating eosinophils and the number of mast cells in the airways. In addition, they reduce airway hyperresponsiveness by reducing airway inflammation. Chronic treatment with inhaled steroids reduces responsiveness to histamine, cholinergic agonists, exercise, allergens, and irritants. They also reduce symptoms and improve pulmonary function. These drugs provide long-term prevention of symptoms and suppression, control, and reversal of inflammation when taken regularly. However, inhaled steroids are not effective for relieving acute episodes. Let's now progress to the dosage of inhaled steroids. The lowest dose required to control symptoms is recommended. The recommended dose is 2 to 4 inhalations 2 to 4 times a day. Inhaled corticosteroids now come in powder form, which is thought to deliver more of the drug to the lungs. Table 25.3 lists comparative doses for inhaled corticosteroids. The dose-response curve for inhaled corticosteroid treatment begins to flatten for many measures of efficacy at low to medium doses, although some data suggest that higher doses may reduce the risk of exacerbations. Most benefit is achieved with relatively low doses, whereas the risk of adverse effects increases with the dose. We will now consider the onset of action of inhaled corticosteroids. It takes approximately 2 weeks of continuous therapy for inhaled steroids to achieve maximum effectiveness. And now let's consider the contraindications of inhaled corticosteroids. These drugs are contraindicated for use in acute attacks and should be used cautiously in children because of the potential impact on linear growth. However, low-dose inhaled steroids can be used in children younger than age 5 with a spacer and a mask. Next we will talk about the adverse events of inhaled corticosteroids. Inhaled steroids usually are well tolerated. Side effects are minimal. The most common adverse events are oropharyngeal candidiasis, dysphonia, hoarseness, cough, and headache. Most of these effects are dose-dependent and can be minimized by using a spacer for delivery and rinsing the mouth after use. Spacers also increase the amount of the drug delivered to the airways. The potential for adverse effects on linear growth from inhaled corticosteroids appears to be dose-dependent. In treatment of children who have mild or moderate persistent asthma, low to medium dose inhaled corticosteroid therapy may be associated with a possible, but not predictable, adverse effect on linear growth. High doses of inhaled corticosteroids have greater potential for growth suppression. Inhaled corticosteroids appear to have no serious adverse effects on bone mineral density. Let's now progress to mast cell stabilizers. Regarding their mechanism of action, cromolyn sodium and nedocromyl inhibit the release of mediators from mast cells, probably by preventing calcium influx across the mast cell membrane. See Table 25.2. They suppress the influx of inflammatory cells and antigen-induced bronchial hyperactivity. These drugs are especially useful in reducing bronchospasm induced by stimuli such as exercise and dry air. These are used as first-line therapy in children because they do not have the potential for negatively affecting linear growth. These agents are not used for the immediate relief of bronchospasm but for long-term control and for exercise-induced asthma. Cromolyn is effective only as an inhaled agent. And now we will discuss the dosage of mast cell stabilizers. The recommended dosage is 2 to 4 inhalations 3 or 4 times a day. Regarding the time frame for response of mast cell stabilizers, plasma concentrations are seen approximately 15 minutes after inhalation. The half-life is 45 to 100 minutes. Any of the medication that is absorbed is excreted unchanged in the bile and urine. It takes 1 to 2 weeks for the medication to become effective, but it may take longer to achieve maximum benefit. Next we will discuss the contraindications of mast cell stabilizers. These agents are contraindicated in acute asthma exacerbations for immediate relief. And now we will look at the adverse events of mast cell stabilizers. Adverse events include headache, nasal irritation, transient bronchospasm, cough, an unpleasant taste, rash, and dry throat. We will now shift gears to leukotriene modifiers. Leukotrienes are potent biochemical mediators, released from mast cells, eosinophils, and basophils, that contract airway smooth muscle, increase vascular permeability, increase mucus secretions, and attract and activate inflammatory cells in the airways of patients who have asthma. Levels of the leukotrienes, potent inflammatory mediators, are increased in asthma. Leukotriene modifiers block the 5-lipoxygenase and LTC4 synthase pathways, preventing leukotriene-mediated bronchoconstriction. They are considered an alternative, not a preferred treatment option, for mild, persistent asthma by the expert panel. They can also be used as adjunct therapy with inhaled corticosteroids for youths aged 12 and older and adults. They are not the preferred adjunct therapy compared to the addition of long-acting beta-2 adrenergic agonists, abbreviated as LABAs. Next we will discuss the mechanism of action of leukotriene modifiers. Zafirleucast, marketed as Accolate, a receptor antagonist, and monteleucast sodium, marketed as Singular, block binding of leukotrienes to the receptor. These medications reduce symptoms, improve pulmonary function, and inhibit acute asthma attacks. They are also thought to have anti-inflammatory properties because they reduce the eosinophil count. And now let's consider the contraindications of leukotriene modifiers. The leukotriene modifiers, which dilate the bronchial pathways from the beginning of use, are contraindicated for the reversal of acute bronchospasm. Their effect on breast milk is not determined, so caution should be used in lactating women. Patients with liver impairment may require lower doses. Next we will discuss the adverse events of leukotriene modifiers. Adverse events include headache, dizziness, weakness, gastrointestinal symptoms, elevated liver enzyme levels, back pain, myalgias, fever, and infection. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.2 summarizing overview of selected drugs used to treat asthma before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.3 summarizing estimated comparative daily dosages for inhaled corticosteroids before proceeding to the next slide. Next we will discuss the interactions of leukotriene modifiers. Blood levels of zafirlukast are increased by aspirin and decreased by erythromycin, marketed as eryomycin, others, and theophylline, marketed as Theodur, others. There is an increased effect of warfarin, marketed as Coumadin, when taken with zafirlukast. Food decreases the absorption of zafirlukast. Increased blood levels of theophylline, propanolol, marketed as Inderal, and warfarin are found when administered with leukotrienes. See Table 25.2. Next we will discuss methylcanthenes. Methylcanthenes inhibit the enzyme phosphodiesterase, preventing the breakdown of cyclic adenosine monophosphate, abbreviated as CAMP. This relaxes bronchial smooth muscle and may prevent the release of endogenous allergens, such as histamine and leukotrienes, from mast cells. The methylxanthines are thought to antagonize prostaglandin-mediated bronchoconstriction and block receptors for adenosine. The main effects are smooth muscle relaxation, central nervous system excitation, and cardiac stimulation. They also increase cardiac output and lower venous pressure. The most common methylcanthene is theophylline. In elderly patients, use of theophylline is considered unsafe because of concomitant disease that may alter theophylline pharmacokinetics, multiple drug interactions, and the frequent inability to tolerate the medication. These are discussed in Chapter 26. We will now progress to beta-2 adrenergic agonists. In asthma, short-acting beta-2 adrenergic agonists, abbreviated as SIR-Bars, are considered rescue medications that relieve bronchospasm. Long-acting beta-2 adrenergic agonists, abbreviated as LABAs, last for 12 hours, but do not act rapidly. See Table 25.2. Short-acting beta-2 adrenergic agonists are the mainstay of treatment for acute symptoms of bronchospasm, but the regular scheduled use of short-acting beta-2 adrenergic agonists is not recommended. The use of more than one short-acting beta-2 adrenergic agonists canister per month suggests poor control. The expert panel concluded that long-acting beta-2 adrenergic agonists are to be used as an adjunct to inhaled corticosteroids for long-term control of symptoms, but not to be used for monotherapy or for treatment of acute symptoms or exacerbations. Long-acting beta-2 adrenergic agonists may be used before exercise to prevent exercise-induced bronchospasm. For the most part, beta-2 adrenergic agonists are inhaled through a nebulizer or metered-dose inhaler, although they come in oral form. It is important that the patient learn the proper inhalation technique to ensure optimal benefit of the medication. The patient who uses more than one canister of these drugs every month is poorly controlled. Next we will discuss the mechanism of action of beta-2 adrenergic agonists. Beta-2 adrenergic agonists provide smooth muscle relaxation after adenylate cyclase activation and an increase in CAMP. This relieves bronchoconstriction. And now let's talk about the dosage of beta-2 adrenergic agonists. The usual dosage is 2 or 3 inhalations every 3 to 4 hours from a metered dose inhaler. See Table 25.2 for doses of oral and nebulizer solutions. Beta-2 adrenergic agonists work rapidly to increase airflow. We will now progress to the contraindications of beta-2 adrenergic agonists. Caution is recommended in patients with ischemic heart disease, hypertension, cardiac arrhythmia, seizure disorder, and hypothyroidism. Let's now briefly look at the adverse events of beta-2 adrenergic agonists. Adverse events include tachycardia, skeletal muscle tremor, hyperkalemia, hyperglycemia, increased lactic acid, headache, hyperglycemia, and dizziness. These drugs can interact with other sympathomimetics, tricyclic antidepressants, and monoamine oxidase inhibitors. They are antagonized by beta blockers. Let's now look at cromolyn and nedocromil. Cromolyn and nedocromil are alternative therapies in children for step 2 therapy. They can also be used as preventive therapy before exercise or unavoidable exposure to allergens. Regarding their mechanism of action, cromolyn and nedocromil block chloride channels and modulate mast cell mediator release and eosinophil recruitment. Regarding their dosage, recommended dosing for both is 4 times a day. Regarding their contraindications, there are no contraindications. Regarding their adverse events include an unpleasant taste, sore throat, rash, and cough. Let's now look at immunomodulators. Omalizumab is the only available immunomodulator. The expert panel recommends that omalizumab may be considered as adjunctive therapy in step 5 or 6 care for patients who have allergies and severe persistent asthma that is inadequately controlled with the combination of high-dose inhaled corticosteroids and long-acting beta-2 adrenergic agonists, abbreviated as LABAs. It is approved for patients aged 12 and older with proven sensitivity to aeroallergens. This should be prescribed and administered by a specialist. We will now briefly look at the mechanism of action of immunomodulators. Omalizumab, a recombinant deoxyribonucleic acid-derived humanized monoclonal antibody to the Fc portion of the IgE antibody, binds to the portion that prevents binding of IgE through its high-affinity receptor, Fc-epsilon-Re, on mast cells and basophils. The decreased binding of IgE on the surface of mast cells leads to a decrease in the release of mediators in response to allergen exposure. Omalizumab also decreases Fc-epsilon-Re expression on basophils and airway submucosal cells. Next we will look at the dosage of omalizumab. The dosage is 150 to 375 mg subcutaneously every 2 to 4 weeks. If more than 150 mg is given, multiple sites must be used. And now we will talk about the contraindications of omalizumab. Omalizumab is contraindicated in patients having an acute asthma attack. Next we will discuss the adverse events of omalizumab. Anaphylaxis occurs in an estimated 0.2% of treated patients, which resulted in an U.S. Food and Drug Administration alert. Most of these reactions occurred within 2 hours of the omalizumab injection, and after the first, second, or third injections. However, reactions have occurred after many injections and after many hours. Therefore, clinicians who administer omalizumab are advised to be prepared and equipped for the identification and treatment of anaphylaxis that may occur, to observe patients for an appropriate period following each injection. The optimal length of the observation is not established, and to educate patients about the risks of anaphylaxis and how to recognize and treat it if it occurs, e.g., using prescription auto-injectors for emergency self-treatment and seeking immediate medical care. Other adverse events include injection site pain and bruising, upper respiratory infection, and headache. And now let's take a closer look at systemic corticosteroids. Systemic corticosteroids are effective in treating an acute asthma exacerbation. See Table 25.2. The expert panel recommends the use of oral systemic corticosteroids in moderate or severe exacerbations. It also recommends that multiple courses of oral systemic corticosteroids, especially more than 3 courses per year, should prompt a re-evaluation of the asthma management plan for a patient. Next we will discuss the mechanism of action of systemic corticosteroids. These drugs inhibit cytokine and mediator release, attenuation of mucus secretion, and upregulation of beta-adrenergic receptor numbers. They also inhibit IgE synthesis, decrease microvascular permeability, and suppress inflammatory cell influx and the inflammatory process. Airway reactivity is reduced by the suppression of airway inflammation, which in turn inhibits mucus secretion, reduces edema of the airway mucosa, and decreases denudation of airway epithelia. We will now look at the time frame for response of systemic corticosteroids. Although these medications are readily absorbed when taken orally, peak plasma concentrations are not achieved for 1 to 2 hours. Short-term, 5 days to 2 weeks, therapy with systemic corticosteroids is recommended for acute exacerbations that cannot be controlled with bronchodilators. Symptoms usually improve quickly with oral corticosteroids, within 24 hours. Next we will look at the dosage of systemic corticosteroids. Treatment is usually initiated with an oral dose of 30 to 60 mg of prednisone daily. The daily dose can be tapered, or a short course of therapy, that is for 5 to 14 days, can be given without tapering. The corticosteroid therapy usually can be discontinued in 5 to 14 days. When symptoms are controlled, the patient is then maintained on inhaled corticosteroids and bronchodilators. If corticosteroids are used in the short term for treating an asthma exacerbation, there is improved efficacy when they are administered at 3 p.m. because the drug mimics the body's natural cortisone level. Short-term treatment should be continued until the patient achieves 80% peak expiratory flow, abbreviated as PEF, or the symptoms resolve. If corticosteroids are prescribed for long-term therapy to maintain pulmonary function, the lowest possible dose should be used. Corticosteroids can be administered in the morning, either daily or every other day. Dosing late in the day may cause insomnia. Dosing every other day may produce less adrenal suppression. Contraindications: oral corticosteroids are contraindicated in untreated infections, lactation, chronic use, and known alcohol intolerance. We will now progress to the adverse events of systemic corticosteroids. Serious adverse events include psychosis and peptic ulcer. Less serious adverse events include nausea, vomiting, dyspepsia, edema, headache, mood swings, hyperkalemia, elevated blood pressure, hyperglycemia, ecchymosis, and acne. Adverse events affecting all body systems are much more common in long-term corticosteroid therapy than in short-term therapy. See Table 25.2. Next we will discuss the interactions of systemic corticosteroids. Systemic corticosteroid therapy may increase the dosage requirements of insulin or oral hypoglycemic agents. Metabolism of corticosteroids may be blocked with oral contraceptives. Corticosteroids combined with quinolones may increase the risk of tendon rupture. The effectiveness of phenytoin, marketed as Dilantin, phenobarbital marketed as Luminal, and rifampin, marketed as Rifampin, may be decreased when using corticosteroids. Pause the video and carefully scrutinize Figure 25.1, which is a treatment algorithm for asthma, before proceeding to the next slide. Pause the video and carefully scrutinize Figure 25.2, illustrating the classification of asthma severity and initiating therapy in children, before proceeding to the next slide. Pause the video and carefully scrutinize Figure 25.3, illustrating a stepwise management of asthma long-term in children, before proceeding to the next slide. Pause the video and carefully scrutinize Figure 25.4, illustrating a stepwise management of asthma for those aged 12 and above, before proceeding to the next slide. And now we will talk about selecting the most appropriate agent. Asthma treatment consists of a stepwise approach that corresponds to the patient's asthma classification, i.e., the features or severity of asthma, as shown in Figures 25.1 through 25.4. Control of asthma symptoms should be achieved as quickly as possible. To gain control, treatment may be started at the step most appropriate to the severity of symptoms, or a higher level. There needs to be a step up if symptoms increase or are uncontrolled. If symptoms are controlled for more than 3 months, there can be a step down that is closely monitored. A rescue course of systemic corticosteroids may be needed at any time and for patients diagnosed in any step for quick symptomatic relief. Acute exacerbations of asthma can be treated with inhaled, short-acting beta-2 adrenergic agonists. If the patient has a good response to systemic corticosteroid therapy, that is a peak expiratory flow of 70% of normal, it may be used to manage the condition with close follow-up. The dose of systemic corticosteroids is 1 to 2 mg per kilogram per day in a single dose for children and 30 to 60 mg per day for adults. We will now briefly look at exercise-induced bronchospasm. Exercise-induced bronchospasm is asthma triggered by intense physical activity. The treatment is long-term control therapy, pre-treatment before exercise with short-acting beta-2 adrenergic agonists, leukotriene receptor antagonists, cromolyn, or nedocromil. Frequent or chronic use of long-acting beta-2 adrenergic agonists for pre-treatment is discouraged because it may disguise poorly controlled persistent asthma. A warm-up period or a mask or scarf over the mouth is recommended for cold-induced, exercise-induced bronchospasm. Let's now take a closer look at first-line therapy, that is Step 1. In the patient with intermittent asthma, symptoms no more than twice a week and nighttime awakenings no more than twice a month, the recommended treatment is an inhaled short-acting beta-2 adrenergic agonist as needed. No daily medication is needed. If beta-2 adrenergic agonists are used more than twice a week, or a canister is used in a month, the patient should move up to Step 2. Regarding second-line therapy, that is Step 2, the treatment recommendation for patients with mild persistent asthma is Step 2. This is a low-dose inhaled corticosteroid. An alternative to inhaled anti-inflammatory therapy is cromolyn, nedocromil, theophylline, or leukotriene modifiers. If symptoms are not controlled with this regimen, there is a need to move to Step 3. And now we will look at third-line therapy, that is Step 3. Step 3 treatment consists of a low-dose inhaled corticosteroid and a long-acting beta-2 adrenergic agonist or a medium-dose inhaled corticosteroid. Alternatives include adding a leukotriene modifier, theophylline, or Xeluton to low-dose inhaled corticosteroids. If the patient is not controlled on this regimen, there is the need to move to Step 4. In children younger than age 5, either a long-acting beta-2 adrenergic agonist should be added to a low-dose inhaled corticosteroid, or a medium-dose inhaled corticosteroid should be used as monotherapy. Next we will consider fourth-line therapy, that is step 4. Step 4 consists of the use of a medium-dose inhaled corticosteroid and a long-acting beta-2 adrenergic agonist. Oral corticosteroids are added as needed. Alternatives include adding a leukotriene modifier, theophylline, or Xeluton to medium-dose inhaled corticosteroids. If the patient is not controlled, there is the need to move to step 5. We will now progress to fifth-line therapy, that is step 5. Step 5 is the use of high-dose inhaled corticosteroids and a long-acting beta-2 adrenergic agonist and the consideration of omalizumab in patients with allergies. Uncontrolled patients should move to step 6. For neonates up to children age 4, the recommendation is a high-dose inhaled corticosteroid and a long-acting beta-2 adrenergic agonist or montelukast. For children ages 5 to 11, a high-dose inhaled corticosteroid and a long-acting beta-2 adrenergic agonist is recommended. An alternative regimen is a high-dose inhaled corticosteroid and a leukotriene modifier or theophylline. Finally, let's briefly discuss sixth-line therapy, that is step 6. Step 6 is the use of high-dose inhaled corticosteroids, long-acting beta-2 adrenergic agonists, oral corticosteroids, and consideration of omalizumab in patients with allergies. In neonates to children age 4, recommended treatment is high-dose inhaled corticosteroids and long-acting beta-2 adrenergic agonists or montelukast and oral corticosteroids. For children ages 5 to 11, treatment is high-dose inhaled corticosteroids, long-acting beta-2 adrenergic agonists, and oral corticosteroids. Alternative treatment is high-dose inhaled corticosteroids and a leukotriene modifier or theophylline and oral corticosteroids. Let's now discuss the special population considerations. Let's begin with the pediatric population. There is strong evidence from clinical trials that inhaled corticosteroids improve the control of asthma for children with mild to moderate persistent asthma. The lowest effective dose is used and growth is monitored carefully. It is the opinion of the National Asthma Education and Prevention Program expert panel that the initiation of long-term control therapies should be considered in infants and young children who have had more than 3 episodes of wheezing in the past year that lasted more than 1 day and affected sleep and who have risk factors for the development of asthma. Risk factors include parental history of asthma or diagnosed atopic dermatitis, allergic rhinitis, wheezing apart from colds, and peripheral blood eosinophils. This applies also to infants and young children who require symptomatic treatment more than twice per week or who have severe exacerbations less than 6 weeks apart. The following medications are recommended for use by children. Budesonide nebulizer solution, approved for children ages 1 to 8. Fluticasone dry powdered inhaler abbreviated as DPI. Approved for children age 4 and older. Salmeterol dry powdered inhaler and combination product. Salmeterol plus fluticasone, dry powdered inhaler. Approved for children age 4 and older. Montelukast in 4 mg chewable tablets. Approved for children aged 2 to 6. And in 4 mg granules. Approved down to age 1. And Cromolyn nebulizer. Approved for children aged 2 and older. Data in children followed for 6 years suggest that low to medium doses of inhaled corticosteroids may decrease growth by about 1 cm in the first year of treatment. But this effect is not sustained in subsequent years of treatment and the final predicted height is reached. The height of any child taking corticosteroids, either oral or inhaled, should be monitored. If growth retardation is seen, the benefits of asthma control should be weighed against the possibility of growth delay. Oral corticosteroids can cause growth retardation in young children and are used only if the exacerbation of asthma is moderate to severe. Instead of using inhalers, children age 5 and younger should use nebulizers or metered-dose inhalers, abbreviated as MDIs, with a face mask to promote maximum delivery of inhaled medications. Figures 25.2 through 25.4 summarize asthma severity and treatment for infants and children younger than age 5, from ages 5 to 11, and from age 12 and up. It is recommended that a written asthma action plan is shared with the childcare or school settings so that treatment can be carried over into that setting. Next we will discuss the women. There may be a decrease in bone mineral content with inhaled corticosteroids, increasing the risk for osteoporosis. Postmenopausal women are already at risk for osteoporosis, so the practitioner should prescribe supplemental calcium, 1000 to 1500 mg per day, and vitamin D, 400 to 800 units per day. Asthma management during pregnancy is similar to management in non-pregnant women, with medications that are safe and well tolerated by the mother and fetus. If oral corticosteroids are prescribed, blood glucose levels should be monitored regularly because of the drug's association with an increased risk for gestational diabetes. Asthma control should be evaluated at each prenatal visit. Asthma worsens in about 1/3 of women and improves in about 1/3 of women during pregnancy. Medications should be adjusted accordingly. There are proven negative effects from exacerbations and poor control on pregnancy outcome, whereas there are clear benefits of good control. Patient education about the importance of good asthma control is essential for improving compliance and self-monitoring. Asthma medications are excreted in small and varying amounts into breast milk. The NAEPP found that there was no contraindication for the use of prednisone, theophylline, cromolyn, antihistamines, inhaled corticosteroids, or inhaled beta agonists for breastfeeding. Patients should be instructed, and strongly encouraged, to continue their asthma medications postpartum with or without breastfeeding. Next we will look at the geriatric population. Because older patients with cardiovascular disease may experience tremors and tachycardia with beta-2 adrenergic agonists, it is helpful to use combination beta-2 adrenergic agonists and anticholinergics to prevent this. Because theophylline clearance is decreased in elderly patients, the buildup of theophylline may exacerbate a pre-existing heart condition, so the drug should be used cautiously in elderly patients. Prolonged use of systemic corticosteroids can have an adverse effect on bone metabolism by decreasing calcium deposition and enhancing calcium resorption, predisposing some patients to osteoporosis. Let's now briefly discuss monitoring patient response. After beginning therapy, the patient should be evaluated in 1 to 2 weeks. Subsequent evaluations every 1 to 6 months are necessary to determine if the asthma is well controlled. If there is good control, the patient should be moved down a treatment step. If control is poor, the patient should be moved up a treatment step. Before moving the patient up to the next step, a careful history of medication use and technique and exposure to triggers is taken. For instance, if the patient has been diagnosed with moderate persistent asthma and has been well controlled on a low-dose inhaled steroid and a long-acting beta-2 adrenergic agonist with a short-acting beta-2 adrenergic agonist as needed, he or she can be tried on a low-dose inhaled steroid with the short-acting beta-2 adrenergic agonist used as needed. The patient monitors his or her peak expiratory flow and uses the short-acting beta-2 adrenergic agonist if the peak expiratory flow drops below 80% of predicted value or if there is increased wheezing. If asthma is not controlled with the intervention initiated, the prescriber must assume that the patient is at the next step and initiate treatment accordingly. The patient should be referred to a specialist if there is difficulty controlling the asthma. If a child ages 0 to 4 requires step 3 or higher, or if a child ages 5 to 11 requires step 4 or higher. Also, specialist care is recommended if a patient has required hospitalization during an exacerbation or immunotherapy or immunomodulators are indicated. We will now briefly discuss patient education. Medication. The various types of delivery systems for inhaled medications include inhalers, nebulizers, discs, and roto systems. Each product includes information on how many inhalations are contained in the device. It is important that the patient does not run out of medications. The patient must learn the correct way to use each system and should have an extra system on hand as a backup for use at all times. These systems are described and a detailed description of their use is provided in Box 25.1. Internet sites for information on asthma include www.aai.org, American Academy of Allergy, Asthma and Immunology, www.lungusa.org/asthma, American Lung Association, and www.nhlbl.gov/guidelines/asthma, guidelines from the National Asthma Education and Prevention Program. The patient with asthma is prescribed a peak flow meter, which measures peak expiratory flow, and is instructed to monitor and record peak expiratory flow. Peak expiratory flow rates measure control and exacerbations of asthma. This monitoring allows the patient to determine when additional intervention is warranted. The practitioner should bring the record of peak expiratory flow readings for review at each office visit. Predicted peak expiratory flow values are shown in Table 25.4, although these may vary by individual. The best personal value is determined by having the patient measure peak expiratory flow rates twice a day for 2 weeks during a symptom-free period, or after maximum therapy. The patient is instructed to do 3 measurements and take the best of the 3. Instructions on using a peak flow meter are found in Box 25.2. The patient is then taught the concept of zones as they pertain to peak expiratory flow monitoring. The zones are green, yellow, and red, as shown in Box 25.3. If the patient is in the green zone, treatment remains as usual. If he or she is in the yellow zone, an inhaled beta-2 adrenergic agonist should be taken right away. The red zone signals a medical emergency, and the patient should take an inhaled beta-2 adrenergic agonist at once and seek medical treatment. All patients with asthma should have an action plan. The contents are outlined in Box 25.3. There are multiple websites for information on asthma. They are listed in Box 25.4. Pause the video and carefully scrutinize Box 25.1 summarizing the directions for use of delivery devices for asthma medications before proceeding to the next slide. Pause the video and carefully scrutinize Table 25.4 summarizing normal predicted average peak expiratory flow measured in liters per minute before proceeding to the next slide. We will now briefly look at lifestyle changes. Since asthma is associated with allergies and is exacerbated when the patient is exposed to allergens, the patient should be aware of triggers and avoid them. Many asthmatics are sensitive to scents and should avoid them when possible. If asthma is induced by exposure to cold, one should gradually warm up or wear protection over the nose and mouth. Pause the video and carefully scrutinize box 25.2 summarizing how to use your peak flow meter before proceeding to the next slide. Pause the video and carefully scrutinize box 25.3 summarizing an asthma action plan before proceeding to the next slide. Pause the video and carefully scrutinize box 25.4 summarizing asthma education resources before proceeding to the next slide. Next we will discuss sinusitis. Sinusitis is an inflammation and/or infection of the paranasal sinus mucosa. The term rhinosinusitis is used by some specialists because sinusitis typically also involves the nasal mucosa. The majority of these infections are viral in origin, nevertheless, antimicrobials are prescribed frequently. It is thus important to differentiate between viral and bacterial sinusitis to aid in optimizing treatment decisions. Viral sinusitis and bacterial sinusitis are difficult to differentiate because the clinical presentations are similar. Viral infections, however, tend to resolve by 7 to 10 days. Persistence of symptoms beyond this time likely indicates a bacterial infection. Bacterial sinusitis can be categorized into acute and chronic disease. Acute disease lasts less than 30 days with complete resolution of symptoms. Chronic sinusitis is defined as episodes of inflammation lasting more than 3 months with persistence of respiratory symptoms. Sinusitis is diagnosed more frequently in children than in adults. Typical clinical presentation and diagnosis of bacterial sinusitis are illustrated in Table 107-4. Between 5% and 13% of viral upper respiratory tract infections in children are complicated by bacterial sinusitis, whereas only 0.5% to 2% of viral upper respiratory tract infections in adults are complicated by sinusitis. Factors associated with the development of bacterial sinusitis include viral respiratory tract infections and, less commonly, allergic inflammation. Other factors that can be associated with sinus disease include systemic diseases, trauma, environmental exposures, and anatomic abnormalities.